वेलकम बैक फ्यूचर डॉक्टर्स। चलो शुरू करते हैं एक बहुत ही हाई यील्ड, crystal clear rapid revision of gestational diabetes mellitus, or GDM. We're going to break down exactly how examiners test this 5-star topic in your NEET PG exams. So let's get right into it, बिना time waste किए. Here's our clinical pathway for today. We'll cover Section 1, Screening and Diagnosis Criteria, Section 2, Initial Management and Goals, Section 3, Oral Drugs and Insulin, Section 4, Delivery and Intrapartum Care, and finally, Section 5, Postpartum Follow-up Strategy. Starting off with Section 1, Screening and Diagnosis Criteria. Okay, by definition, GDM is just increased insulin resistance in an otherwise normoglycemic female. Now, here's the absolute game changer, the exam pearl you need to remember. Dhyan rakhna, unlike pregestational diabetes, there are no congenital anomalies in GDM. None. No GCA? Because of this, a fetal echo is not routinely done. Examiners literally love to trap you with this, so mark it as super important. For diagnosis here in India, we rely on the DIPSI criteria. And honestly, the best part about DIPSI? Zero fasting required. Irrespective of her last meal, the patient walks in, and you give her 75 grams of glucose mixed in 300 ml of water. You can even add a little lime if she wants. She drinks it within 5 to 10 minutes. Then you just check her 2-hour postprandial or PP level using a plasma-calibrated glucometer. Timing-wise, do this at the very first antenatal visit. If it's normal, repeat it at 24 to 28 weeks, making sure there's at least a 4-week gap. Bahut simple hai. Moving right along to Section 2, Initial Management and Goals. So you've got the 2-hour PP values. What do they actually tell us? This table is pure gold for your MCQs. Look at the brackets. If the value falls between 140 and 199, that is straight up GDM. But look at the 200 mark. If she hits 200 or more at that first antenatal visit, she actually has pre-gestational diabetes. However, if she hits 200 later at 24 to 28 weeks, it's GDM and you need to start treatment with insulin right away. The trick here is checking when the test was done. Timing is everything, guys. Once you've diagnosed her, we need strict targets. Honestly, ratta maar lo inka. Memorize these metabolic goals. Fasting blood sugar under 95, 1-hour PP under 140, 2-hour PP under 120. And hemoglobin A1C absolutely must be under 6%. Also, average capillary glucose under 100. Our entire management strategy revolves around dragging those sugars below these exact lines. You literally can't proceed without knowing these. All right, Section 3, Oral Drugs and Insulin. So what's our initial strategy? Keep it very logical. If her 2-hour PP is mildly elevated, between 140 and 199, we start with medical nutrition therapy, or MNT, for exactly 2 weeks. If she meets the goals, great, continue MNT. If not, step up to metformin and then insulin if needed. But wait, what if that 2-hour PP is 200 or more? Boom! Start 8 units of insulin immediately, bina soche. Add MNT and wheat counseling too. And side note, there's absolutely zero role for aspirin here, okay? Let's chat about metformin. This is our go-to, first-line oral drug, especially for obese females. It is officially recommended by the Government of India. But remember, it's used only in GDM, not pre-GDM. We dose it from 500 mg up to a maximum of 2 grams a day. If she needs more, you add insulin. Why do we love it? It decreases excessive maternal weight gain, neonatal hypoglycemia, and macrosomia. But watch out. While GI upset is the most common side effect, lactic acidosis is the most dangerous one. Examiners will definitely ask about that complication. These Government of India guidelines make decision-making so easy. Just follow the timeline. Diagnosis after 20 weeks, start metformin. Diagnosis before 20 weeks, start insulin. And like we just said, 2-hour PP over 200 at any time, start insulin. So if a question says a patient is at 18 weeks, you directly click insulin. No second guessing, just click it and move on. When we do give insulin, we strictly use the human premix. That's 30% short-acting and 70% intermediate. Store it in the fridge at 4 to 8 degrees Celsius. And hey, fun fact for clinical practice, the syringe can be reused up to 14 times. You give it subcutaneously exactly 30 minutes before breakfast once a day. Also, remember the natural physiological trend here? Insulin requirement goes up as the pregnancy advances, but then it drops sharply during labor because the patient is NPO. Now, how do we calculate that starting dose? Just remember the 4-6-8 rule based on her 2-hour PP levels. If it's 120 to 160, give 4 units. 160 to 200, get 6 units. And more than 200, 8 units. It's a super quick, foolproof way to calculate the initial dose when you're solving clinical scenarios. Okay, so you gave the initial dose. Now we titrate. You check the levels on the third day. If goals are met, perfect, keep the same dose. If not, here's how you fix it. If the fasting blood sugar is over 95, the problem is the night before, so you add 2 units pre-dinner. If the 2-hour PP is over 120, the problem is the morning, so you add 2 units before breakfast. You just recheck every 3 days and keep tweaking until those targets are locked in.
Let's jump into Section 4, Delivery and Intrapartum Care. The million-dollar question, when do we deliver? Listen, don't rush to induce. If she has type A1 GDM, meaning she is beautifully controlled on diet alone, you can comfortably wait until 39 weeks or more. For type A2, meaning she's on drugs, if she's well controlled, again, wait till past 39 weeks. But if she is not well controlled, delivery is indicated past 37 weeks. Make sense?
And what about the mode of delivery? Vaginal delivery is always the preferred mode. Having GDM does not mean an automatic C-section. We only do an elective cesarean if there is an absolute indication, like massive macrosomia. Specifically, if the estimated fetal weight is 4.5 kilograms or more. Otherwise, normal delivery it is.
During active labor, the whole game changes. The patient is NPO, running on IV normal saline at 100 milliliters per hour, so we use a sliding scale right in the 500 ml IV bag. If sugars are 90 to 120, add 0 insulin. 120 to 140, add 4 units. 140 to 180 gets 6 units, and 180 or above gets 8 units. Wait, actually scratch that. If she suddenly drops into hypoglycemia, below 70, you stop and immediately start IV 5% dextrose. Keep a close eye on this.
Finally, Section 5, Postpartum Follow-Up Strategy. The baby is out, but as clinicians, our job isn't over. Look at the massive difference in postpartum care here. For your standard GDM patients, check their blood sugar on day 3, and if it's fine, discharge them. But for pre-GDM patients, total shift. Once the placenta is out, their insulin requirements absolutely crash. You have to shift them back to oral hypoglycemic agents by day 2, otherwise they'll go into severe hypoglycemia, and always refer them to an endocrinologist.
Why do we track GDM patients so strictly after discharge? Because they have a huge risk of developing permanent type 2 diabetes later on. The protocol is check on day 3 and discharge, but then you must advise them to come back at 6 weeks for a 75-gram, 2-hour OGTT. Even if that's totally normal, they need to get that same 75-gram OGTT annually for the rest of their lives. It is a non-negotiable follow-up. All right, I'm going to leave you with a classic tricky scenario right from the exam notes. Think back to our diagnostic criteria. If a patient vomits exactly 20 minutes after drinking that super sweet 75-gram glucose load during her DIPSI test, what is your immediate next step? Do you push through, or do you stop and reschedule? Drop your answers in the comments. Keep revising these high-yield topics, and I'll catch you in the next explainer.